Some have, of course, obviously, some in our position is that we would support block granting the Medicaid program entirely, but that's not in the realm of possibility given the politics in D.C. Is there something short of block granting that would change your opinion about? In other words, if they change the terms and conditions short of block granting, could we then be in a position where it would be a good decision to take the money, and what are the nature of some of those changes you would seek?
Great point, Bill. I do, in fact, strongly support block granting, not only just for this expanded population, but for the whole program in general.
Sure.
Rhode Island had been in a block grant situation for several years, granted under the Bush administration, and they demonstrated substantial cost reductions in their Medicaid program without compromising access or quality of care. So it's not a question.
What are some of the things they've done to achieve that?
They've been given the liberty to define the portfolio of benefits that are offered. Certainly co-pays have been something that has allowed.
Where the patient has to make some payment, and it's not 100%.
Some payment up front, and this is a big thing that's important to me is people having skin in the game.
Right.
And so they've incorporated what really are largely the things that have occurred out in the private marketplace. They've taken them and applied them to the indigent health care program. And I'm absolutely of the belief that everybody can afford to pay some amount of money when they access the services, access healthcare services. It's been proven not only in Rhode Island, but it's actually been proven here in the state in some of the county programs that provide services to the low income out there. They say, look, give me 50 cents, give me 75 cents, give me $1.50. And when people are, expected to do that, that financial accountability for their health improves substantially. And if you take it to the other extreme and look at health savings accounts, you have people that look at the provision of their health care in a much more discretionary way, one that largely reflects market forces out there. And so they become pretty informed, intelligent buyers of health care. The best example of that is things that aren't covered by health care insurance, and that's radiokeratotomies, Those come down in cost. People have figured out
surgery for those who are not.
Yeah, I'm sorry. So for nearsightedness, you could put a few cuts across the cornea with the laser. It heals up to 24 hours, and you could see. It's great, And one time they were very prideful of it.
The cost over the years has gone down.
Costs have gone down. The quality of the lasers have gone up. The ability of people to access that particular kind of care has improved tremendously.
Right.
And how can you explain it but for current competitive market forces out there that allowed it to happen? The other great example is cosmetic surgery, typically not covered under health insurance. People shop for cosmetic surgery based on quality and cost. I can afford so much. This is where I'm going to go get it. This is who's going to provide it, and I'm willing to pay that amount of money to have that done. So we see market forces play very well. It's interesting because when I was in the hospital business and in anesthesia, very hard to get cosmetic services provided in a general hospital setting because there's so many overhead costs associated with care there that in order to try to bring that particular service in, it largely, if you work on it, it comes out as a loss. And so you see most cosmetic surgery done and done very effectively in these more ambulatory, freestanding facilities, even some office-based facilities now.
Obviously, a lot of those issues that you've discussed apply to private health insurance and the whole. And some believe, as I do, that the whole purpose of the Affordable Care Act is to make the system collapse on itself and go to a single payer. We think that tragically many businesses, large and small, are simply going to drop their health insurance, and even with the subsidies, individuals will have more out-of-pocket expenses for insurance. Therefore, they will not buy insurance. Therefore, actually increasing the percentage of Americans who don't have health insurance. What are your thoughts? I mean, do you agree with that theory?
You've laid it out very well. I think that's exactly what will happen, probably will happen. Whether it was an incredible plot to put that together, and make that happen, the bottom line is it did happen.
Right.
And I think that the whole thing of a public option will come back up in years as we see this whole thing sort of start to collapse. And I think it's incredibly complicated and one that ultimately, certainly under this administration, a single payer system is and a very large government support or responsibility for healthcare is the mindset that this administration has. And they didn't get exactly what they wanted during the last, or when the Healthcare Reform Act passed in 2010. But they set up kind of a mechanism or a system that has so many moving parts to it. The likelihood of failure, I think, is extremely high.
Now, we are, I think the decision is generally made not to have a state-run exchange. Would you agree with that here in Texas?
Well, as you know, I carried that bill in 2011.
And we supported your legislation.
We had really, and I appreciate that, we had very broad-based support for that. It wasn't a liberal conservative, dynamic. It was people saying the sovereignty of this particular issue needs to stay in the state of Texas, and we need to have our control over it, whether it's a federally mandated program or not. The idea of ceding, this program to the feds, just rubbed me the wrong way. In fact, it was the whole first page of the bill that I declare this is why I'm doing this. It's not because I'm a big fan of Obamacare, which most of y'all know I'm a big critic of. But I really didn't want to see the federal government having their hands on this and somehow influencing in a way that I didn't want to see happen that part of our economic sector. But that's what's happened, and we kind of have run out of time to be able to put that exchange together in a way that we would be comfortable that meets the needs of Texans. And by not being in that game right now, we do put ourselves in a position to say, we would like some different sort of things in our exchange, put you in a negotiating position to talk about that. Again, on balance, I have to say I'm more uncomfortable about the feds actually going forward and creating this exchange than what we might negotiate out of it.
Do you think there is hope for negotiation?
Oh, I think so. I don't think the feds really thought that this many states would choose not to participate in the exchange, because I think they probably thought, much like I did, is that well, why would the states want to cede this to us, the federal government? They hate us anyway. So why they'll just do it themselves.
For the average Texan, somebody who, let's say they're employed, they have insurance now. We think there's a high probability that maybe tomorrow they won't have insurance because premiums are going to go up substantially as a result of the ACA. What would be the difference for an average Texan in terms of a federally run exchange versus a state-run exchange, would you say?
I don't know exactly. I think federal versus state, you're still going to have to comply with what the federal mandates are, short of getting some sort of exceptions to the provisions that are in there. I think that, though, having much more direct control of it would at least allow us the opportunity to better tailor it to the state's needs. And I don't know how caught up the federal government is really in this whole exchange thing. As I've said many times before, an exchange is not synonymous with Obamacare in my world. An exchange is a way to buy and sell something.
Privately run exchanges, states have set up exchanges
and they work very well. Right. Yeah, and stock exchange works, I guess, pretty well. The cattle exchanges work pretty well. Cattle exchange. So it's just a way to buy and sell something. Right. And unfortunately, the idea of an exchange, of which, as you point out, we're already in place and very successfully in the private sector and in other states, in fact. It just got synonymous with Obamacare. And if you had political ambitions that would hurt you on that, then you'd have to say, I can't be part of that.
Sure.
In my district, I'm pretty fortunate that I can work in that sort of area and get a pass on that, So,
well,
but not
I do want to say we appreciate it because, as I said earlier, I think what you're about in terms of your service is about good public policy, and let the politics be damned, which is sort of what the model we try to follow, and that's why we were supportive of your legislation.
Well, thank you. Thank you for those kind comments. But ultimately, I think that even if we got a block grant, which would be the best of all worlds, you would have to have an exchange in place to operationalize that thing.
Right.
So
and
all of a sudden
they're way behind in terms of the rules and the operations and everything. I mean, it's
for the federal.
Yes, sir.
Yes, exactly.
It's a complete nightmare.
I think that again, I think it caught them off guard that they didn't have any idea that this many states would say we're not going to do it. Yeah. Now again, from a political posturing point of view, it's kind of put the federal government back on their heels a little bit, and that's never a bad thing when you're trying to negotiate a better position on $100 billion. Right?
But we discussed this really briefly before your being up here. You're still pessimistic that that I think it's 25 states who have refused to accept the expansion now.
Correct.
But even given the fact that so many states have refused, and obviously the Obama administration wants the expansion of the federal coverage through Medicaid, you don't think that they would be willing to negotiate what you and I might consider a reasonable solution short of full block grants? You're pessimistic about that, is that correct?
Well, I somewhat,
Okay,
but
well, I don't mean to put words in your mouth.
somewhat, but I do think that if you were able to bring together, you know, these 20+ states that have said, look, we don't like this, it doesn't work for us, but we know that for Obamacare ultimately to be successful, you're going to have us at the game.
Right.
Come together and say, here are some provisions. Okay, let's say we write off the idea of a block grant, although I put it on the table for this expanded population. Okay, we can't get that. Maybe we can get, you know, 1, 2, 3, few things, you know, let us manage portfolio, let us manage the, you know, the ability to create the co-pays. And some of these things actually are baked into the expansion in the rulemaking process. But something that allows us to really create something that looks much more like a private insurance policy out there. And really start to recognize that, you know, these entitlement programs aren't meant for you to be in your whole life.
Right.
They're meant to be a bridge for you to ultimately, you know, your life come, you know, into a little better situation and you move into the private sector.
Like welfare, I mean, like time limits on welfare.
Well, exactly.
Which have been very successful in our opinion.
Yes, and I think that we have just come to think that the Medicaid program wants a Medicaid client forever a Medicaid client.
Right.
And it doesn't need to be that way.
Well, I want to reinforce, I think that the people of Texas are very lucky to have someone of your caliber and talent working on these critically important issues. Would you please join me in a round of applause for